So, thank you for coming, everyone. I'm going to walk around because, as you see, if I stand and you'll stare at me, I can't speak. But I can definitely speak if you allow me to walk around a little bit. Thank you for coming today, and what a place we have. Never been in here before. Has anyone seen the velodrome? So the velodrome is just down there. And when I finish, because Leslie, you now need to do half an hour from here. It would be no chance for 15 minutes, especially after what you see there. And remember, that was Chris that screwed that up. Okay, so have a wee look at the velodrome. Jim's downstairs, get a walk around. I do have a video of James doing. James, put your hand up at the back. James, Derek, Asher. Higher, Asher. Team SCED Lab. And I asked James about 3-4 weeks ago, James, can you actually record what you do in the lab and show everyone the kind of digital workflow? And just because if you haven't seen it, you won't see these scanners doing their stuff. What did you say to me, James? And the next bit? So long as? So you don't have to speak, I've got it in video. Everyone knows who we are, so let's skip past this. But what I wanted to, when you come to doing an update and an introduction to new technologies, let's not be smarty pants about implants. These things, and people have had the idea of replacing teeth from forever, from time beginning. 4,000 years ago in China. So when we think we're being a wee bit smart with what type of implant we place, what type of abutment we're using, people have had the idea that we need our teeth. We have to eat, we have to function. And then as new technologies come on, we sometimes get it a wee bit wrong. But remember, when this was done, no one had a real idea of what worked and what didn't work. What do you guys see here? Shout it out. Implants, good, yes. How many? 40. Aye. It's the beginning of all on something, it's all on 8. And funnily enough, the bone levels seem to be hanging on relatively well. But that's not what we're doing now, as you can imagine. So my aim today is to, in half an hour, quickly get through some of the new ideas. But before I do that, I thought, if you're referring your patient, remember this is all about patient care. There's nothing that we're talking about today that doesn't have a patient at the end of it until Chris maybe comes on at the end, and then it's more about us as a team. So if you're sending a patient to a referral practice, it's kind of a bit handy to know what sort of things are running through our minds and what options we have. And the game plan is to get through the options, talk about the ASC, talk about the new locator, talk about full arch options, and then get to the digital laboratory. And as I say, I've got absolutely no chance of getting through all that unless I talk fast. So let's start the story with how should we place an implant? Should that implant go in on the day you take the tooth out? That's if the tooth is still there. Should it be delayed? And we've all got slightly different thoughts on this. Or should it be completely delayed? Should we come back well after the socket's healed? And why? And I guess the first thing that we're thinking about doing is to get patients through either a full arch CBVT or a partial CBVT. And when I was taught to do dentistry, and most of us in here will have met Letitia and our team of radiologists, we're very anti-radiographs, and it's understandable stochastic damage that happens to people because of radiographs is something we have to consider. But there's very little chance of getting implantology correct unless we do this first. Because the day of lifting massive flaps and having a look at bone and telling the patient they can't have their implant either today or ever has gone. This is the new technology. We have to embrace it. And when we get that, someone called Joseph Kahn up here, dentist in California, made a classification that said, well, actually, if you look at what position the tooth is in, you can then decide when you thanks. You can then decide when you place the implant. So sometimes you'll send a patient to us guys and we will decide to take the tooth out, put the implant in, and sometimes you're getting a story back that says, oh, by the way, it's better to wait 6 months. And it's very difficult unless you understand where the tooth sits in the alveolus to know why that is. And therefore, when someone tells you they do implants without 3D radiography, I don't get that in 2019 now, because you have to know whether that buccal plate in front of this upper anterior is there, and you have to know whether that tooth is the buccal plate, or whether it sits in the middle, or whether it sits palatally, or there's no bone round about it. If you take that tooth out on a conventional method, that's the patient that ends up with the acrylic denture with the large pink flange on it. And as dentists, we then think, oh, hang on, that was the same type of extraction as I did 2 weeks ago, and the patient came back and all the bone and the tissue was there. And now I did the same thing a week later, and I now need to make another partial denture, now a big flange on it, because you never stood a chance. Never, ever stood a chance. And how many teeth collectively in the room have we all taken out as teams? And yet, we're not sure where the tooth is. Now, I'm not suggesting that every patient gets a CBVT, but it's an interesting prequel to a conversation that is to be had with the patient is, what type of restoration do you want to have? Because even if it's a bridge, you probably still want to know what that is. And so, how do we remove a tooth and what should we use is quite important. And hopefully, I can encourage you to buy some periotomes. Linda, you got the periotome sales list out here, yep. So, on extracting the tooth, I'm taking a scalpel. I want to sever the periodontal ligament, and then I want to use my best friend, a periotome. So, I had never used a periotome until I decided I wanted to do implants, and they are the easiest things in the world to use. So, a periotome is essentially the thinnest luxator that you'll ever use in your entire life. And that tiny little periotome is going to go up the periodontal ligament, and when you mallet the periotome round about the tooth, you then move it like a little knife. And what that does is allows that tooth to actually fall out as you mallet it up round about it. Then, as if I'm a salesman for some of the equipment companies, but again, Salvin will sell you these guys, and they're called twist forceps, and it's this part up here that you're looking for. Please have a wee look at looking for forceps that have those beaks on them. You will find that extractions are the easiest things in the world with them. They go up so far, and you can maintain the buccal plate with them, and they'll get you out of jail so many times when you've got roots that you just can't get hold of. And this is my total last resort. I think I've used it maybe about half a dozen times in SCED, and usually that means things have gone really wrong. It's a kit by Meisinger, and what you do with it is you drill, as if you're doing a post in a tooth, you drill into the tooth, you place this device on a taut wrench, you then boost this part here into the root by putting it anti-clockwise, and as you turn the taut wrench clockwise, it brings the tooth out like that. And what you've did there is you've removed the tooth like a corkscrew, and it is absolutely my get out of jail when I know an implant's going in and I can't get to that root. Now, none of this really qualifies as the update, but sometimes if we make a backside of getting a tooth out, there is nothing we're going to be able to do with an implant. If the tooth comes out with a buccal wall on it, and we've all did it umpteen times, you stand no chance after that. So it's periotomes, twist forceps, and Meisinger's Apex Control Kit on extractions. I just thought that was worth the 5 minutes. Now let's get to the interesting stuff. So, the early days of doing implants, Warwick University, come out and everyone's saying, right, okay, how do you plan a case? Planning a case was an upper and lower set of alginates, a wax up, and a little stent that says this is where you should place the implant. Not anymore. So, what was quite interesting, I like that, see the C on there? College of Architecture and Planning, pretty cool. So the old workflow was, patient comes in, they want a fixed tooth, we place an implant and we work out whether the guys at the back of the room and Asha can actually make a crown on it. Nowadays, thanks to digital dentistry, we can then work our way back. And I put this slide up because about 2 years ago, I had absolutely no idea where this whole digital workflow was going. It was going to cost a fortune. There was so many companies you could buy equipment from, and some of it worked, and it's been a hell of a journey. There's a little thing I'll show you in a second called a scan flag. I've had so many sleepless nights over scan flags. Scan flags are made by every different Tom, Dick and Harry company under the sun. Interestingly enough, each individual scan flag relates to an individual implant and therefore has to be read by a library by a scanner. And if that scanner doesn't have the library or mistakes the scan flag for something else, your printed crowns and milled abutments come back completely not fitting, or they're 2 millimeters out. And James, you could fill the story in there umpteen times. We have got it right now, but we have the biggest box of unused scan flags in SCED. So if anyone wants to buy scan flags for different systems, let us know, because some work and some don't. And what we're now using is Nobel Clinician. And Nobel Clinician is a fabulous piece of software where we can actually, to begin with, design where the crown's going to go and work our implant back the way. And so we start with our CBVT, decide what type of placement, try now to get the tooth out without removing the buccal wall, which, like I say, it doesn't always happen. We're then aiming to have an intraoral scan. We're going to marry the intraoral scan with the CBVT, and then this software does it all for you. So this bridge that's getting planned here actually pops up on the screen, and we can then develop. When I say we, where is she? Louise? Louise? We's Louise. So I usually start my planning when Louise has that on my screen, and then I can work back from it. We can then have a wee look at what we want to do, create a surgical guide. Although I have to say, I've placed this picture of a surgical guide up. That's fully guided surgery. Most of the time now, I'll create a pilot guide, because there's still a place for human judgment here. So when you've got the computer, you can guide it all the way in, but if you create a pilot guide, you've still got a chance to alter it with what your eye sees rather than what the computer said. So you get your first drill, and then you can adapt so that basically the hole's not as big. Our implant goes in. How am I doing, Leslie, for time? Okay. And this is the traditional way of doing implants. So the implant with an abutment and with a crown. And as everyone's sitting there quite silent, can anyone give me what the Achilles heel of a dental implant is? What's the bit that most likely to go wrong, that it sucks? One, guys. For all you guys have got implants, patients with implants in the surgery, what do you dread Monday morning, first patient? And not implant failure, because that is a dread, but it's far less common than this. It's the abutment screw loosening on a cemented crown. So everyone take a wee minute to get their head around about what that means to a patient. So that's a patient that's had a tooth out, had the stress. Can everyone for a minute think of their most stressed out patient, hardest patient to deal with? Take a sec, all right? Referred, gets a tooth out, goes through the journey perhaps of a temporary for 3 months, comes back to tell everybody that they hate their temporary, gets their implant works, gets their crown, and within 2 years their crown's moving. So they pick up the phone, they turn up to the practice, you give the crown a wiggle, and you say, oh my goodness, the actual screw that holds that crown to the implant has loosened off. And if that crown is cemented on, how you get into the abutment screw? It's a 2-minute fix if you haven't cemented that onto the abutment. So this is where, and that's the problem, that screw turning back inside the implant. So where we have a fix for this, sorry, I'm going to come to that in a wee minute, I'll come back to this. Where we have a fix for this is in Nobel's angle screw correction channel, and to be fair, many other implant systems are doing this now. So what they're doing is they're allowing the angle of the abutment to implant to be corrected by 25 degrees. Now that might not seem a lot, but what it means is, if everyone turns to the person beside them and looks at the facial profile of their front teeth, nose and lip, and imagines that the bone that sits like that creates teeth like this. Just everyone smile at each other, 2 minutes. You as well, Chris, get off the computer. That's not a smile, that's a smile. Kevin, smile, thank you. Okay, so anything that's in the anterior zone really needs to have an implant that conforms to where the bone is, and that means that that implant is coming out like this. Where does the angle get corrected? With the abutment. And traditionally, the crown was then glued on because the angle was broken by the abutment and the crown was glued on. Not anymore. I haven't cemented a crown in the anterior this year, Erin. Not unless it was a replacement for an old one, and maybe not last year. And what's happening here is the screwdriver that comes through the crown is able to hit the part that screws it in at an angle. But what it means is that we've got to go to all of our prosthetic kits, so for all the guys that work on prosthetics of implants, and go back to Linda and buy the Omni driver. How much is an Omni driver? £54 for an Omni driver versus making a patient a brand new crown is a deal. So this is saving my life in terms of relaxing when I place, because I'm not sure which one will unwind. But what I will say to you is that you cannot control your patient's mouths for the rest of their lives. Someone will lose a posterior tooth that bore the weight of someone's occlusion. When they lose that tooth, even though you've created the correct occlusion for the anterior, it will change and they will put weight on that anterior and the abutment screw will loosen. And if that crown is glued on, it's an interesting conversation about who's paying the £1,000 for the new crown. So if I can appeal to your back pocket, do an ASC channel. And it works for the back ones as well. And of course, now that we're using printed models, we can now scan the patient, and that's me going back to that picture. And these are the scan flags. So these parts here are so important that they must be read by the individual scanner that you have. So again, I think we've got that right, James. We haven't had a problem for over a year now. Or have I just wasted that now? So that's the first wee bit that I wanted to say. And as far as people who want to get involved in implant restorations, this is probably the best bit that you want to see today. We have to get screw access crowns. We've got to get away from cement. We could even have a conversation about cement and peri-implantitis, and that's where you'll come in, Jolene, in a wee second. But if I just appeal to patient care, if I get an abutment screw that loosens and the patient has an access here through the crown, that's 5 minutes to fix. Between two, it's the easiest emergency to fix. If that's cemented on, you're drilling the crown off and you don't know where the access is. And the patient's not happy you're drilling it off because they've just spent money on it. And how am I going to temporise this and all sorts of questions. So now I wanted to move, Leslie, 5 minutes. Okay, full arch restorations, I changed when I moved from Prestwick to SCED, because SCED was a big Noble Biocare centre, and Paolo Malo at this point was suggesting that an all-on-4 style restoration was definitely the best way to go. And the reason for that is that, and this is not new, but the next bit is. So the reason for that is that you can miss the mental nerve with angled implants posteriorly, which means that you can then cantilever the implants back the way. So in other words, if they were straight implants, you'd be placing implants from 3 to 3, whereas if you cantilever them back, your implant gets to the 5, and it's the same in the upper with the sinus. So an angled implant at the back corrected by a multi-unit means that your implant gets further back in your mouth, which then means you can support further teeth towards the back. And that's pretty standard now for a fixed arch restoration. The problem is, if I've got my slides in the right order, so there you are, this happens more often than I would like. So again, people will say to me, I bet when you go to SCED, there's never an implant that doesn't work and nothing fails. Oh, no, no, no. The more complex the treatment plan, the more work you've got to do to a patient, the more that you, with an upper and lower, forces that you put on a fixed restoration, the more chances you've actually got of things going wrong. And the things that go wrong are, the catastrophic things that go wrong is they can fracture in half on the cantilever, or this is quite a regular occurrence where you'll get a tooth pop off. And remember, the patients, always put you do anyway, yourself in the shoes of your patients. The patients might have spent 28,000, £30,000 on this. And so a tooth coming off at any time in the next 5 to 10 years is not good. And it usually happens on Christmas Eve. So it got me thinking, how can we change? And I don't always get patients like this, where this was a 50-year-old lady that I could place 6 implants on and still do a fixed arch bridge, because this lady had the bone in the tissue. So despite the high smile line, she still had it all. Perio is present, but we were able to fix the teeth. What I get more is Alexander here. So this is an 80-year-old man that is just absolutely terrified about going to the dentist, and maybe has become one of our favourite patients. And what we're going to do for Alex is we're going to place the 4 implants. Again, these ones at the back here are angled multi-unit screws, multi-unit abutments, changing the angulation. And then we're going to give him temporaries. But what I know is that if I give Alex those acrylic mallow bridges, the chances are at some stage in his life he's going to walk in with a tooth coming off that. So things have to change. So we start looking with James, different options that we can do, and we came up with a nice try-in, and then sent this to Createch. So this is now chrome, milled into essentially what is, I can't remember the count, I think it's 6 to 6 and 6 to 5 preps done on the cobalt chrome. Then this is now Derek's work, where so the gentleman is in his 80s and he doesn't want pink gums. So he says, I don't want my teeth to look like they're piano keys, although he did choose BL4 in the end. So, of course, Derek creates the gingivae, and each one of these teeth are individual crowns cemented onto that framework. And that's the final result for the gentleman, and he was delighted. And at least now, if I get a fracture or a problem, I've got an individual tooth that I can fix, as opposed to a full acrylic bridge that needs to come off and then get repaired with cold cure acrylic. How do your dentures do when you repair them with cold cure acrylic? That's now a temporary denture, isn't it? So imagine that on a full arch mallow bridge. Patients have maybe spent thousands and thousands of that, and you know that your upper left tooth is re-cemented back onto it. This now is just an individual crown setup and can be fixed. And what's better is that each one of these crowns has a file on the lab scanner, so when the patient comes in and perhaps has fractured the upper right 3, we can ask for an upper right 3 to be milled from the centre, and so long as Derek remembers the staining he did, it'll be perfect. And the gentleman was delighted. Younger man, Neil, 45, and again, well, not again, but perio, ex-smoker, and just a wee bit too young to give a set of dentures to, in my mind. And these are all whistling in the wind. So we got him from there to there by using something called zircon zan. And one of the great things about zircon zan is that you can then replace soft tissue and hard tissue like a mallow bridge, but this time this is all zirconia, milled again with a file. And that's another massive game changer. So now we can actually get the soft and the hard in something that I feel is going to be durable for 10 to 15 years. And so I guess in any talk about an update, there's always the temptation for me to try and become smarty pants here. And let me not finish with this part about navigated surgery and say it's the complete final thing at the moment. I'm trying to think of the word. But there's two systems called Navident and SCED. SCED's Nobel's, Navident is Clarinav. And these things are coming down from the technology that's used for brain surgery and heart surgery at the moment. So the Galileo's machine? Galileo's, I think it is, that does heart surgery, where the doctor's kind of sitting in the corner here on a PC and there's two surgeons watching a machine do the heart surgery, is same technology. And what's happening here is that we can then now take a guide of the patient, CBVT, connect them up to markers, and then we park sense our implant into place using the exact same sort of thing as parking your car. So you know your Mercedes, you press the button and it reverses itself into a car parking space. We are getting there with implant surgery, except it needs a perfect CBVT. And if the guys that were here that are developing this, they'd cringe when I say this, because how many of your patients that need implants don't have metal ceramic crowns in their mouth? Or amalgams, or gold inlays, or anything that's metal, which means that every time you take a CBVT, you get scatter, and then when you take the CBVT with scatter and marry it to an intraoral scan, it could be just slightly out. And if it's just slightly out, how much do you trust this machine? I would trust it in parts of my mouth more than in others. For example, you kind of got to be watching that if it's got two crowns either side of it. So what I'm getting at is this will become the future, but if you're looking at a lower left 5 and you've got a crown in front of that 5 and behind it and there's scatter off it, I'm not using guided surgery, but it's going to come. And what these guys at Navident did last year in China was use a robot that was then designed to have a jig onto the teeth and was operated by a dentist that wasn't in the same room, and they placed the implant and it was a very successful placement. So you can see what's coming. And you know what usually happens with technology, once they get it right, it'll accelerate through. And these things cost a fortune, but as soon as people start buying them, they'll be like flat screen tellies, we'll all have robots placing their implants. And there you go. What a size of a nose that is, eh? So although the machine's telling me what to do, I'm still looking at kind of in disbelief. This might have been one of my first shots of this machine. I could not believe that it does what it says it does. And you have to get the green line and it goes the full depth. When, for example, you can do some interesting things with this. When you've got the machine rigged up, you can take an implant drill, an osteotomy drill, and place it down into your hole, and it'll tell you where exactly you are inside the osteotomies. And it means you can double check, and you can't do that obviously in any other way. And then you can place your implant, and also you can connect your implant up to the machine so you can actually see your implant get into the jaw. Which is quite fascinating. So, did I make it? Yeah. So please pop in to see us. I think we know everybody that's in the room.